Welcome back. In this episode, we're going to be discussing a paper that looks at risk factors in primary angle closure glaucoma. I'm Dr. Mika, and our guest expert for this episode is Dr. Nathan Lighthizer, who's an associate dean at NSU College of Optometry in Tahlequah, Oklahoma. Welcome, Nate.
Glad to be here, Mika. Thanks for having me.
So this article is entitled Risk Factors for Primary Angle Closure Glaucoma, a Systemic Review and Meta-Analysis of 45 Studies by Wang and colleagues, which was published in the Academy's journal, Optometry and Vision Science. Now, there are a lot of papers out there looking for risk factors for glaucoma, and this one is specifically looking at angle closure glaucoma in particular. And we know that the risk for severe visual impairment is much higher in angle closure glaucoma compared to primary open angle glaucoma. So it seems like a great topic for a paper. Tell us a little bit about this study.
Yeah, Mika, it was a really great big study, a meta-analysis looking at 45 studies that were included, cross-sectional, case control, cohort studies. Again, looking at primary angle closure glaucoma. They excluded a variety of things like case reports and abstracts and non-English literature and anything like that. But again, they looked at what are these different risk factors, and they looked at a lot of different categories of risk factors for angle closure glaucoma. As a reminder, this was not an angle closure suspect, which I'll talk about in just a little bit, or even angle closure. It was primary angle closure glaucoma. So they actually had glaucomatous disease, optic neuropathy. They looked at general morphological, physiologic lifestyle factors, ophthalmic parameters, comorbidities, serological parameters, medications. They looked at a lot of these different categories, and they said, what is more likely to lead a patient to have primary angle closure glaucoma? And what they found was under the general morphological, physiological, and lifestyle factors, it was lower body weight, family history, were the two main things. And I think family history makes sense. We factor that in glaucoma all the time. I'm not sure I have a great explanation for why the low body weight is a risk factor, but it was. Ophthalmic parameters to me are the most self-explanatory. IOP level, anterior chamber depth, those shallow anterior chambers, axial length, those shorter axial lengths, so more hyperopes, retinal nerve fiber layer, and then spherical equivalent increased, likely in that room, your hyperopia once again. So I think this makes sense. IOP, again, we're talking glaucoma here, not angle closure suspects. So IOP makes sense, those crowded, smaller eyeballs. Lastly, the comorbidities, it was cataract and hyperlipidemia. There's theories on why the hyperlipidemia may play a role. Hard to explain on that. Triglyceride levels, and then your medications like antidepressants, topiramate, again, affecting pupil size, ciliary body swelling, et cetera, et cetera. So lots of different risk factors for primary angle closure glaucoma. Most important, I think, the ophthalmic parameters that we touched on.
So that makes a lot of sense. No huge surprises coming out of there, but let's say you have a patient who's a suspect, so not yet glaucoma, not primary angle closure glaucoma, but they're a primary angle closure suspect. How would you go about managing that?
Yeah, so again, remember your primary angle closure suspects, they don't have glaucoma. They're not even in angle closure. They're just at risk, like our POAG suspects, our suspects before they have POAG, our primary angle closure suspects. They're a suspect. What does that mean? They're narrow. They've got failure to see the posterior TM in at least two quadrants, 180 degrees. They are narrow. They have no synechiae, and they have no elevated IOP, and they have no optic neuropathy. They are just narrow. Laser PI has traditionally been one of the treatment options for patients that have narrow angles. Well, we know that a PI is going to be indicated if they're in primary angle closure. If their IOP is elevated, they're developing synechiae, there's really no debate. They need a laser peripheral iridotomy unless they're ready for cataract surgery. A laser PI is the way to go, as well as in primary angle closure glaucoma. You got to open up that angle with a laser PI. Again, briefly, the EAGLE study has shown that cataract surgery is likely superior to laser PI. So if your patient is anywhere close to cataract surgery, that may be the superior option. But let's directly to your question, a primary angle closure suspect that's not ready for cataract surgery, laser PI may be indicated, it may not be indicated. The ZAP study told us that a laser PI reduces the rate of angle closure by 47% over 6 years. That was statistically significant. However, it cut the risk from about 4% to about 2%. which is again about a 47% risk. But when you take it from 4% to 2%, is that clinically meaningful? The ZAP trial said maybe not. You got to do a lot of PIs to prevent one case of angle closure. So, for that reason, widespread use of prophylactic laser PI was kind of recommended against, unless they have significant posterior segment disease. You're going to have to dilate them a lot. They're not likely to come back for care. They've got a family history, things like that. So your primary angle closure suspect, could you do a PI? Yes, if they have the right risk factors, but could you also monitor? And the answer is yes, based on the ZAP study as well. So I think we over PI'd people a lot over the last 10, 20, 30 years. And the ZAP study, among others, has said it's okay to monitor those patients. And the vast majority, 96% in that study, did not go into angle closure over the course of 6 years.
I mean, that's really compelling. I get what you're saying about, we were over PIing people, but circling back to this study that's sort of confirming what we already suspected about these risk factors, is there anything differently that I should do in my practice in terms of like considering some of these risk factors? And should that make me be faster to go to PI, even though we've been over PIing people? Should I monitor those patients more closely? What can I do with this data?
Yeah, this data to me said, again, look at those risk factors. And if your patient is a primary angle closure suspect, they might be more likely to go through the stages and get to glaucoma if they've got a shallow anterior chamber, if they've got a short axial length, if they have IOP issues, if they have a family history, cataract, hyperlipidemia. If you start adding up these risk factors, and they have a lot of them, that patient, you need to follow more closely, watch more closely. Maybe it's a PI, maybe it's a cataract surgery, but that patient with a lot of risk factors, more likely to progress to the glaucomatous form of primary angle closure.
Well, that makes sense. Thank you, Dr. Lighthizer, for joining us today and giving us all this great information about primary angle closure glaucoma.
My pleasure to be here. Thanks, Mika.